Hello, everyone, and thank you for joining us. I'm Casey Minnis. I'm the Director of Communications for the Multiple Sclerosis Foundation, also known as MS Focus. And I'm glad that you could be here for this educational program. Today, we are going to talk about walking issues in MS, and our presenter will be Dr. Ben Thrower. Dr. Thrower is the Medical Director of the Andrew C. Carlos MS Institute at Shepherd Center and the Senior Medical Advisor for the Multiple Sclerosis Foundation, and a recognized expert in multiple sclerosis. We're delighted to have him here today to present this information. And Dr. Thrower, I'll turn it over to you.
Great. Thank you very much, Casey. And thank you to everyone who is joining in. I hope everyone is staying safe and healthy. And if it's as hot where you're at as it is here, I hope you're managing to stay cool as well. This is actually one of my favorite things to talk about in MS because when we think of walking issues, it has so many different facets and it affects so many people with MS in so many different ways. And one of the ways that we know that it's a common issue in multiple sclerosis are from surveys like this. Now this is a few years old, from 2001. It's from a group called NARCOMS, the North American Research Committee on MS. Some of you might actually be participants in this. This is a national registry where people send in data on different issues and help us collect information for research in MS. And what this shows is a survey of thousands of people with MS looking at how many people have walking issues in multiple sclerosis. Let me see if I can get this off of here. There we go. And the take-home message from this is that in this survey, 85% of people with MS reported some degree of walking issues. It was really, if you see in the yellow that I just highlighted, it was really the minority of people. Only about 15% of people in this survey reported absolutely no issues with their walking. And obviously there were different gradations of how severe the walking issues were, from very mild impacts on walking to people who were completely unable to walk. And when we think of what does that mean in a person's life, one of the ways we can think about the impact of walking is on vocational abilities. So these two graphs break out both men and women with how walking is impacting their ability to work. I'm sorry. So the orange bars are people who are working full time, and the kind of the grayish blue bars is walking issues. And so what you'll see as you go across both the graphs in both men and women, as walking gets worse, the likelihood that the person is working full time goes down. So orange bars down as blue bars go up. So obviously walking has big impacts on people's life, including their ability to work full time. So I always think of walking as sort of like a ripple in a pond in some ways, in that it has other effects. What we do see in some people is that as their walking is impacted, some people get nervous, they get embarrassed about how the walking is affecting them, and it leads to this sort of cycle of things that are not necessarily good. As the person becomes has more difficulty walking, sometimes we see people pulling back from activities. They don't want to go out because they're afraid maybe they get stuck, they get tired, they're not able to walk. They don't want to be embarrassed by using maybe an assistive device to help walk. This can sometimes lead to depression. We sometimes see issues with deconditioning, what we call disuse atrophy, more weakness and deconditioning. And this cycle just kind of goes around and around. So we want to be very aware of how walking impacts someone's quality of life and do everything that we can to push that negative cycle back in the positive direction. because just like those, that ripple effect can spread outwards. If we impact one of these areas, sometimes we improve quality of life in multiple other areas. So I think of walking issues as like a witch's brew, and there are a lot of different ingredients that can go into this this brew. And we're going to talk about 5 different things that can impact walking in a person with multiple sclerosis. We're going to talk a little bit about spasticity. We're going to talk about foot drop, nerve fiber fatigue, sensory ataxia, and cerebellar dysfunction. So spasticity, that word comes from the Greek term spastikos, or to tug. It's a motor disorder. It's a problem with the muscles. And the technical term, if you ask a medical student to give the correct definition on a test, the correct definition of spasticity is that it is a velocity-dependent increased resistance to passive stretch. And so what that means is that if we were to move say your elbow, if I were to move it slowly in a person with spasticity, maybe I get a little bit of sense of tightness. But if I were to try to move that muscle very quickly, you're going to feel it go rigid and push back. That has impacts when you're doing your stretching exercises or someone's helping you passively stretch. Whenever we're doing stretching in the setting of someone who might have muscle tightness or spasticity, we want to be slow and gentle, because the faster we go, the more that muscle is going to tighten up due to the spasticity. We see an increase in deep tendon reflexes, or the stretch reflex. So when your healthcare provider taps on your knees and then looks at your reflexes and your knee jerks out, that's a deep tendon reflex, or a tendon jerk, or a stretch reflex. Those are all terms for the same thing. And so one of the signs of spasticity is when we tap on your reflexes, you have these very hyperactive reflexes. We sometimes call those get back reflexes, because if the person tapping on your knee doesn't get back, they're likely to get kicked. So what are some of the other signs that we see with spasticity? Again, we see these hyperactive reflexes. We see muscle spasms. Those are, so the person who's experiencing spasticity may have outright painful spasms, or they can just have tightness in the muscle all of the time. Clonus. So when we talk about those deep tendon reflexes, the most exaggerated deep tendon reflex that we can see is called clonus. And one of the ways that we see that on examination is that if we push up on the bottom of your foot and your foot goes dun 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 and starts bouncing, that's clonus. If you ever get your leg in a funny position and the leg bounces uncontrollably, that's clonus. That's an exaggerated deep tendon reflex. What you're doing is you're making an electrical arc. You're sending a signal from the tendon in your leg up to the spinal cord, and the spinal cord is sending the signal right back down to the muscle, telling it to contract, and that reflex arc is just firing over and over again. Most people find that if they move their leg or push down on it, it will break that circuit and stop that sort of firing. Spasticity can be painful to some people. It impairs voluntary muscle control. And so if you had to describe the most classic way that spasticity would look, the cartoon character there. So this is someone who has spasticity in both the upper and the lower extremity. Spasticity in the upper extremities tends to cause increased flexion. So in the arm, it's going to make everything want to flex. Your elbow is going to flex, your fingers are going to flex, your wrist is going to flex down. So you end up with a curled, pulled in, tight arm, like you see the gentleman doing. In the legs, spasticity is extensor. It wants to extend and tighten everything. So you have this leg that doesn't want to bend, and the foot can be pushed down. So this can be problematic if you're, say, trying to get into the car and the leg wants to tighten up and you're having a hard time bending it to get into the car. So arms flex and legs extend with spasticity. When we think about stretching exercises, that's an important concept to remember. When you think about stretching, you're going to stretch in the opposite direction that spasticity wants to go. So when you stretch the legs, you want to try to bend the leg to stretch those extended muscles. When you're going to stretch your upper extremity, your arm, you're going to try to extend that arm to do your stretches. So this is an interesting concept for people that might be new to spasticity, in that spasticity is not always a completely bad thing. Spasticity can actually have some good implications as well. So when we think about treating spasticity, we want to keep that in mind. One of the things that we sometimes do is get physical therapists involved to help us get a sense of how much the spasticity for a given individual might actually be a good thing. So some of the good things that we see with spasticity is it can help maintain muscle tone. It can actually assist with walking and transfers. So if you have a lot of weakness in your legs and now you stand up, you go to, say, get from chair to bed, and the natural response is for those legs to want to extend and tighten, you may actually be using that increased extensor tone to help with your transfers, or to help deal with underlying weakness in the legs. If we aggressively get rid of someone's extensor tone in their legs, say with a medication, we may actually make their function worse. We might actually impair their ability to walk and transfer. So that's again where sometimes the physical therapist can help us out in helping us judge how aggressive to be. Interestingly, spasticity may be associated with a lower risk of deep venous thrombosis or clots in the legs because of that muscle tone. There are bad things that go along with spasticity as well. So you can have impaired function. Again, if that leg is super tight and stiff, maybe it impairs your ability to get into the car, or it's driving your foot into the floor in a way that makes walking more difficult. A lot of people have spasms in the night, and so it can interrupt their sleep. It can make hygiene difficult. So if your legs, so one of the forms of spasticity we see in the legs is called scissoring, where both legs want to cross over one another. Makes it hard sometimes with just personal hygiene. And then if you have tightness in a joint over long periods of time, you can actually get contractures. So the tendons actually start shrinking and tightening up, and then it makes it really difficult for us to loosen that muscle up, because not only is the muscle involved, but now the tendons attached to that joint are involved. So traditionally we think of managing spasticity in a stepwise or ladder fashion. So at the bottom of the ladder, the first step is removing noxious stimuli. We'll talk about what are noxious stimuli. So these are things that irritate your body and may actually be associated with worsening of spasms and spasticity. The next notch up would be rehabilitation therapy. Then we're going to look at oral medications, and then at the top of the food chain would be intrathecal baclofen. So things that could irritate your body and irritate spasticity are just numerous. So I would say the most common by far would be urinary tract infections. If someone calls us and says, I was cruising along doing fine, and now all of a sudden my spasms are just going nuts, and I don't know what's driving it. It may be that there's an underlying UTI. Any infection can do it, but in the MS community, I would say UTIs are the most common. And the challenging thing for many people with MS is that the UTI symptoms that a person with MS deals with may be neurological and not urological. So in the non-MS community, we look for things like, burning with urination or blood in the urine or fevers. And those things can happen in a person with MS, but sometimes they don't. And what we're dealing with is just a worsening of neurological function that is the underlying symptom of a UTI. Kidney stones, when women have their period, sometimes that can make spasticity worse. Any GI irritations, bowel upset, just being gassy sometimes will make spasticity act up. We mentioned other infections, pneumonia, deep venous thromboses, If the MS is worsening itself, that may cause spasticity to worsen as well. Stress and sleep deprivation, common thing to make spasticity act up. Something as minor as an ingrown toenail, clothing that doesn't fit well. So if you have, it's clothing that's rubbing on the foot, or a tight shoe can do that. Fatigue, we mentioned stress, psychological factors, changes in temperature and humidity. So a lot of people with MS are aware that they have heat sensitivity, but some people with MS also have cold sensitivity. As they get chilled, their spasticity may actually worsen. So what are the physical and occupational therapists going to help you with? Stretching exercises, so they're going to do stretching with you, and also hopefully give you a good program to go home with so that you can keep that up. Weight bearing. So if someone is non-ambulatory and they're really never bearing weight, maybe the physical therapist can put that person in a standing frame to help them get some weight bearing in a safe and controlled fashion to help with spasticity. Botox injections. So Botox is going to temporarily paralyze a muscle. If that's a muscle that is giving you trouble with spasms or spasticity, and it's a muscle that we can do away with, and meaning it's not going to impair your function, maybe a Botox injection might be an option for you. Serial casting is something that we do for really severe spasticity. So if you have a really tight joint, what serial casting involves is they're going to sort of get that joint into a more desired position and put it into a temporary cast for maybe a week or so, have you come back. They're going to extend the joint a little bit more, put it into another cast, so that just slowly over time, you're really putting that joint into a more normal position. And then pool therapy is a great way of sort of taking some of the weight off of someone and maybe putting people through more aggressive range of motion that they might not be able to do in other situations. So these are our medications that we look at for spasticity. Baclofen is our old standby. It's been around forever and a day. We use it very commonly. The general rule with baclofen is you're going to start with a low dose and you're going to titrate upwards until the person with spasticity is either happy or sleepy. And so if you hit the point where the person is too sedated, you're probably at the highest dose you're going to go to. The other thing we have to be aware of with baclofen is it can unmask underlying weakness. So typically with baclofen, we feel like we can give you enough baclofen that we can make your muscles looser. The question is, can we do it without making you weaker? And can we do it without making you sleepy? The right dose of baclofen varies tremendously from person to person. It really just depends upon the individual. So the next line, diazepam, clonazepam, and lorazepam, these are in a class of drugs called benzodiazepines. These do work well as muscle relaxants. They can be used for anxiety as well. The downside is they do have some potential for addiction and tolerance. So a dose that works for an individual may not work after a while, and you may have to think about going up on the dose. And there is the potential for addiction with these drugs. They are controlled substances. There's some street value to these medications if they get out into the wrong hands. Dantrolene is an interesting drug. It is something that is used for spasticity for reasons I cannot explain. I can't tell you why it doesn't work as well in our MS community as it does, say, in people with spinal cord injury or stroke. Across from the hall from our MS Institute here at Shepherd Center, we have what we call the multi-specialty clinic, and that's where the rehab doctors are working with people with spinal cord injury or stroke or traumatic brain injury. They use dantrolene by the buckets full over there, and it works really well in that patient population. It just doesn't seem to do quite as well for people with MS. We try it sometimes if some of our other options are not working, but just have not been as impressed with it. I would say after baclofen, tizanidine is probably the next most commonly used medication. Great antispasticity drug. It works differently from baclofen. It can also be sedating. Sometimes we actually put the two together to complement one another. Keppra is actually a seizure medication. It's not so much used for chronic muscle tightness or spasticity, but if you're having big waves of muscle spasms, we can use it there to try to knock down some of those painful spasms. And then lastly, cannabinoids. So these are the active ingredients in marijuana. The two that we're most familiar with are CBD and THC. We know that these chemicals do have antispasticity properties, and there's a lot of research and ongoing, gaining of knowledge as it relates to these chemical compounds. There's a synthetic version called dronabinol or Marinol. Marinol is synthetic THC. There's no CBD component to it. It is FDA approved for nausea in chemotherapy patients or in intractable nausea or weight loss in HIV patients. We have pulled it out of the hat sometimes to use in multiple sclerosis. The challenge that we have with Marinol is really two things. So CBD and THC kind of complement one another. CBD tends to take some of the potential for getting high away from THC. With these cannabinoids and MS, we're not trying to make people high, we're trying to make them functional. And so the lack of the CBD in Marinol or dronabinol, for some people is a problem. We do see some individuals who are sensitive to it and say, no, I don't like the way it makes me feel. It's also, Marinol is an off-label product for spasticity in MS. It's not FDA approved for spasticity, and it's expensive. And so we are at the mercy of the insurance carrier in terms of whether they want to pay for it or not. Sativex or nabiximols is an interesting one that you're probably going to hear more about over the next couple of years. So nabiximols or Sativex is real deal cannabinoid. It is a mixture of CBD and THC from a pharmaceutical company called GW Pharmaceuticals. This has been approved by regulatory agencies in 23 different countries for spasticity and spasms in multiple sclerosis for at least 10 years. We're just slow to the game here in the United States, but we are starting phase 3 studies this fall on Sativex for spasticity and spasms in multiple sclerosis. This is a sublingual spray that generally has a low side effect risk. The advantage of this over, say, using medical marijuana, if you're in a state that allows you to use that, is this, in theory, would be covered by insurance. And then, again, there's obviously a lot of other cannabis products out there. Depending upon where you live, you may be in a state that you can use some form of medical cannabis. Here in Georgia, what our law says is that people with MS can be in a registry. They can have a card that will allow them to use a 5% THC oil for managing symptoms in multiple sclerosis. And then finally, we have intrathecal baclofen therapy. So we know if you put baclofen into the spinal fluid in a concentrated liquid form, it works very well for spasticity. So when we take baclofen by mouth, it's absorbed in the GI tract, it goes into the bloodstream, it goes to the liver. Some of it is metabolized through the liver and is just immediately not available to your body. Some of it goes across the blood-brain barrier into your brain. That is not where we want baclofen working. The baclofen that crosses the blood-brain barrier and goes to our brain is where you're getting the drowsiness from. Where we want baclofen working is in your spinal cord. And so one way of getting baclofen directly to the spinal cord is to just put a concentrated liquid form directly into the spinal fluid. So then in theory, you're getting all of the good without the bad. The challenge with intrathecal baclofen is it is a surgical procedure. So this device you see is about the size of a hockey puck. It's surgically implanted under the skin on your side. You have a small tube that runs under the skin and delivers that concentrated liquid baclofen into the spinal fluid. Generally, these pumps will hold about 3 months or so of the liquid baclofen. You go back into the clinic then and have the pump refilled. Just do a little injection. All of these pumps have a security code, so the healthcare provider who's working with you would hold a little wand over your pump. They can access the code to your pump, and then they can make adjustments to your dose. They can turn the pump on and off. They can then refill the pump through a little injection. So we're going to shift over now to foot drop. So if you had to pick the two weakest muscles in the legs in a person with MS, it's going to be your hip flexors and your ankle dorsiflexors. So your ability to raise your hip up, your knee up, and your ability to raise your foot up off the floor. So if you have weakness in your ankle dorsiflexors, if that's all you were dealing with, one of the ways you would compensate for that is you would do something called a steppage gait. You would use your hip flexors to bring your foot up off the floor by just flexing your hip. So you'd really bring that knee up super high to clear your foot. The problem with MS is if your ankle dorsiflexors are weak, I'll almost guarantee you that your hip flexors are weak. So most people with MS cannot do that steppage gait. So one of the ways that people end up compensating for foot drop is they circumduct their leg. So rather than the feet going in this nice to and fro motion when you're walking, on the weak side, the person will swing that leg out and around. They circumduct. A lot of times the person with MS is not even aware they're doing it. If you're not sure if you're doing it, if you're tired one day and you feel like your walking is not great, have someone watch you walk from behind and tell you, hey, is one of my legs kind of swinging out and around? We want to be really aggressive in managing foot drop, because if you just let the person go over years with that circumduction pattern, they end up putting a lot of stress on their knee and their hip and their lower back, because you're using muscles to walk and you're moving your joint in a direction that you really weren't designed to do for long periods of time. Traditionally, if we send you to a physical therapist for foot drop, they're going to prescribe you an ankle foot orthotic, and we'll show you some pictures of those. A lot of people don't care for ankle foot orthotics. We get frowny faces when we think about ankle foot orthotics. Ankle foot orthotics, this is a traditional AFO, or this is a toe off. This is a little bit different version of an ankle foot orthotic. So why don't people sometimes like ankle foot orthotics and toe off devices? They are, if you were wearing them in the summer and you're wearing shorts or a skirt, some people don't want everyone to know that they've got this device on. They can be rigid. Some of them don't bend, and so it feels a little unnatural. They can be a little uncomfortable. They may not fit in the shoes that you want them to fit in. We joke sometimes that the most common time I think that some of our patients wear their ankle foot orthotic is when they're coming in to see us in the doctor's office, and I think they're doing it just to make us happy. And the rest of the time, the device is probably sitting in their closet. So we want to make people aware that these are out there, but also make them aware that there are other options. So if a person has very mild foot drop, maybe they just need something if they're going to be really walking a long distance. There are all kinds of over-the-counter devices out there. This is one example. It's called the Dorsey strap or the X strap. Really simple device. You can go on their website. They're about 40 bucks, thereabouts. It's a simple insert that goes behind your heel and laces up into into your shoe. So it's not going to give you any lateral support, but it's going to help you get your toes up just a little bit. So if maybe you only have foot drop if you walk a long ways, maybe you're going to Disney World, you know you're going to be walking a lot, and you don't want to risk your foot dragging, this may be a simple solution for dealing with that. Kind of a notch up, you have a little heavier duty device called the Sabo device. This one, so the Dorsey strap again runs about 40 bucks. I think the Sabo device is about 150. It's sturdy. It's a really sturdy collar around your ankle. You've got these little metal cables that come out and clip into your shoe. And you'll notice on the front of that, there's a tensioning knob. You can actually crank that up and determine how much you want your foot to come up. These things are sturdy. We have people who hike in these. They'll put up with a lot of abuse. So then we move into kind of some of the higher tech devices. So we've known for decades, maybe 100 years or more, that if we electrically stimulate your peroneal nerve on the outside of your knee, so if you feel the outside of your knee, you'll feel a little bony prominence, a little bony knob. Right behind that bony knob is the peroneal nerve. That peroneal nerve is is the nerve that controls the muscles to bring your foot up. So if we electrically stimulate the peroneal nerve, we'll make your foot come up. So we've known that for years, but the question is, how do we turn that into something useful? And so there are two devices out there that people with MS should be aware of. So one of them is called the Walk Aid. So the Walk Aid is a little lightweight knee brace. It's got a peroneal nerve stimulator built into the device. It functions based upon acceleration and tilt. So when you work with a physical therapist on this device, they're going to set the parameters for this device to fire based upon when your knee accelerates and tilts. And that's the signal that says, okay, this person's trying to take a step, they're trying to bring their foot up. I need to electrically stimulate that nerve and make the foot come up. The problem with the Walk Aid device is that those are set parameters. The physical therapist has to set those at a certain level. As a person with MS, your acceleration and tilt, your parameters are not set. They're dynamic. They look different in the morning than they do in the afternoon. People with MS fatigue. People with MS get overheated and their weakness looks worse. So sometimes the Walk Aid device works well and sometimes it doesn't work well because it's not set at the right parameter based upon how fatigued you are. So generally we like this one a little bit better. This is the Bioness device, or the L300. This was the original version. So in the original version, you had the cuff on the knee with the nerve stimulator. And I don't know if you can see down on the inside of that person's right foot, there's a little clip on the shoe. That clip is a radio telemetry device, and it's sending a signal back up to the stimulator to say, hey, this person's trying to walk, they're trying to step, you better fire the nerve. So this is dynamic. It can change as your weakness changes. It's not at a set parameter. They called it the Plus because you can also put an upper cuff above the cuff that's on here to help work on the knee flexors or knee extensors, so you can hit more than just the lower leg muscles. This is the newer version of the L300 called the Go. So what they got rid of with this was the clip on your shoe. So this now has built into it sensors that sense your environment and can tell when you need to fire that nerve. So the nice thing about not having the clip on your shoe is you can use this barefoot, or you can use it on a wider variety of shoes. And it is still dynamic. It's not, these are not set parameters. It's going to adapt as your weakness changes throughout the day. We love these devices. As a physician looking at someone in the exam room, I might think someone would be an ideal candidate for one of these devices. Honestly, you never know if you really are until you get in and work with a physical therapist. So that's what we do, is we'll send folks to the physical therapy and say, hey, physical therapist, and let them try these out. If in your area, your local physical therapists are not familiar with these devices, you can have them call the Bioness company. Bioness will send out at no charge a physical therapist that is trained to work with your local physical therapist to determine if this is going to be a good fit for you or not. So this in our clinic, this is what one of these looks like in action. This is a woman walking with her walker with her ankle foot orthotic on, the AFO, and she's going 10 meters, so a little over 30 feet. And you can see with her ankle foot orthotic on, it took her about 91 seconds to go 10 meters. Now she puts the Bioness device on, takes the ankle foot orthotic off, and she goes that same distance in about 40 seconds. So she is walking twice as fast with the Bioness device on. And if you kind of project that over the course of the day, that's pretty significant. I mean, there's a lot of practical implications of being able to walk that much more quickly. So we're going to shift on to nerve fiber fatigue. So nerve fiber fatigue is very, very common in multiple sclerosis. We think about 70% of people with MS have nerve fiber fatigue. How do you know if you have it? If you have any neurological symptoms that worsen with exercise or with heat or with both, that's a form of nerve fiber fatigue. So what's going on with nerve fiber fatigue? I'll only torture you with a little bit of physiology, but on the top is the way a myelinated nerve fiber in the brain or spinal cord should work. So that you've got these sort of little sausage links on end, if you will, with little gaps where they're joined together. Those gaps are called nodes of Ranvier, and that's a little naturally unmyelinated area. And what's happening with the electrical information that needs to go up and down that nerve is the electrical information is jumping from gap to gap to gap very quickly, very efficiently. Now MS comes along and it strips a big chunk of that myelin away. So you've got this naked nerve fiber. And so you can no longer have that electrical information jump that big of a gap. So what has to happen is that electrical information has to be reconducted in little tiny baby steps across that gap. It works, but it doesn't work as well as the original equipment did. That gap in the nerve fiber is also prone to something called conduction block. So if you raise your core body temperature, or if you use that nerve fiber where the myelin has been damaged, if you use it again and again and again, like with exercise, you're draining the battery. Eventually that naked nerve fiber is going to say, I'm taking a break, I'm stopping for a while. It's important to know you're not damaging anything. You're not hurting that nerve fiber permanently. You've just drained the battery electrically. When you cool off, rest, relax, it's going to recharge and be good to go again. But what this might look like is, let's say you take a walk and you start off, going down the street and you're doing pretty well. And now, you get a block and now that foot's starting to drag a little bit. And you go a little bit further and now it's really dragging. And now you got to call somebody to come and pick you up because the leg is so weak that you can't make it back home. Or maybe you get overheated and your vision starts to dim in an eye that you've had optic neuritis in previously. That visual phenomenon with overheating is the classic sort of form of nerve fiber fatigue. Some of you may have heard of a thing called Uthoff's phenomenon or Uthoff's phenomenon. So Uthoff was a neuro-ophthalmologist in the late 1800s who described people with having dimming of vision when they got overheated. And he said, you know what? I bet most of these people have multiple sclerosis. And so he actually started, putting people who he suspected of having MS in a hot tub to see if their vision would dim. And that was their way of diagnosing MS back in the day when they didn't have MRIs or spinal fluid examinations. So what do we do to help treat nerve fiber fatigue? Well, if heat is an issue, we just need to work on keeping your core cooler as much as possible. So there are all kinds of cooling vests out there. The MS Focus folks, the Multiple Sclerosis Foundation has a great free cooling vest program. You go on their website and check that out. There are, again, a lot of different versions out there. Some of the newer ones are much, much nicer than our older ones. They're much slimmer, they're much more efficient. And then we have two oral molecules. There's 4-aminopyridine or 4-AP and dalfampridine. These are really very, very similar molecules. 4-aminopyridine has been around forever, for decades. It is a potassium channel modulator. It's going to work on those naked nerve fibers and help those nerve fibers work longer before you drain the battery. So this is a non-FDA approved molecule. It's compounded in mom and pop pharmacies. Curious thing, about probably 15 years ago now, a pharmaceutical company, Accorda, said, you know what, that's a really cool molecule. What if we could get that FDA approved and patented for symptoms in MS? Well, you can't try to patent a drug for exercise or for heat sensitivity. So they had to pick something very specific to study. And what they picked was walking. So what they wanted to show with Ampera or dalfampridine was that you could improve walking in people with MS, and they did. So Ampera is sometimes called the walking drug. Again, it's a very, very similar molecule to 4-aminopyridine. We never thought of 4-AP as just a walking drug. It can improve that, but it may also help with someone's vision, that gets blurry if they get overheated. So we use both forms of the molecule. Ampera is now generic, so it's helped some in bringing the price down. One of the curious things about 4-aminopyridine and dalfampridine is, why don't they work for everybody with MS? And we don't know the answer to that. If you had asked us years ago what we would expect in terms of someone's response, we would have said, well, everybody with MS is going to get a little benefit, maybe some people more than others. But what we really see is that it's almost an all or none phenomenon, that some people get a lot of benefit and other people get nothing. And you will, if you start one of these medications, you're going to know generally within about 4 weeks which group you're in. A couple of precautions: we don't want to use these medications in anyone with a history of epilepsy. We want to be cautious using them in someone with kidney disease. And occasionally I've seen these medications worsen underlying neuropathic pain. If you have burning in your feet, or if you have trigeminal neuralgia, I've occasionally seen these medications make those things act up. Not permanently, just when you're on the medicine. If it did happen and you stop the medicine, it's going to go away. So we're going to shift now to sensory ataxia. So ataxia is a medical term that means that you have a lack of voluntary muscle coordination. In other words, you walk like you've had a drink too many. Sensory ataxia means you walk like you've had a drink because you don't have normal sensation. One of the most important forms of sensory input in a human body is proprioception, or position sense. Every joint in your body has a position receptor. So if you were to close your eyes and move your finger up or down, you generally should be able to tell which way you're moving it, even though you can't see it. Well, if that position sense is impaired, especially in the feet, it's going to throw your balance off. So people that have sensory ataxia tend to feel a little uncomfortable in dark situations or on uneven surfaces. They might walk with their feet a little further apart just to help with their balance. I don't know if any of you have seen the T-shirts that some people with MS have, the "I'm not drunk, I have MS" shirts. Several of the folks we work with have these. One of our ladies that we work with, her husband has the partner shirt. His says, I don't have MS, I'm drunk." So what does this look like? The person's going to walk with their feet further apart, so they've got a bigger base. They use what we call improvised assistive devices. They know where their partner is. They know where the furniture is. They know where the walls are. And then sometimes we use official assistive devices, so canes and walkers. There is a risk of falling when people have sensory ataxia. What does the human body do to try to make up for the lack of sensory information it's getting from the feet? It's going to use your vision. It's going to use the visual horizon. So you can use your eyes to help determine if you're tilting one direction or the other. When we tend to see people at higher risk for falling is when they inadvertently take away their visual cues. So if you're walking and you have sensory ataxia, and now you turn your head to look at the person next to you, well, you're no longer focusing on the visual horizon, and people tend to get a little bit off balance. If you get up in the middle of the night to go to the restroom and there's no night light on, you've taken the visual horizon away. Standing in the shower with your eyes closed to get the shampoo out of your eyes, you're taking away your visual horizon. And many of you may know there's nothing soft to land on in the bathroom if you fall. So we want people to be very aware of not taking their visual cues away. So let me go back here for a second. So just one other thought. So on what do we do for treatment? We don't have anything yet that's going to repair that damage. What we do know, though, is if we work on your core strengthening, we're going to make your balance better. And so that might be through yoga. It might be through something fancy like hippotherapy or physical therapy on horseback. But anything that we do that strengthens your core is going to help minimize the impact of sensory ataxia. And then the fifth ingredient that we're going to touch on in terms of walking issues in MS is cerebellar dysfunction. So the cerebellum is that primitive back part of our brain. It doesn't control sensation and it doesn't control strength. It controls how much we move. So what would a person with cerebellar dysfunction look like? Maybe if they're trying to reach out and touch something, they can still touch it, they can still grab it, but as they try to get to it, they're going to have trouble actually coordinating that movement and stopping where they want to stop. Truncal ataxia with cerebellar issues is just that the person has a hard time controlling their sort of their axis, and they tend to wobble a lot when they're just standing. So we mentioned that you can have dysmetria or tremor, so that's the tremor of the upper extremities. Issues with walking, pretty common with this. The cerebellum also controls speech to a certain degree, and so some people with cerebellar issues with MS have something called a loss of prosody. Prosody is the normal intonations in our voice, the highs and lows. When we want to emphasize something, we give a little more oomph. Loss of prosody is the inability to do that. So the speech has an odd sound to it because there's not the normal intonation of up and down. So what do we do to manage cerebellar dysfunction? We work a lot with the therapist to help with this. Medications for the tremor, I wish we had better options. We sometimes try out a drug called primidone or mycilene. It's an old seizure medication. It's a barbiturate. It sometimes helps a little bit. It can be pretty sedating though. There is some place for something called deep brain stimulation. So what the deep brain stimulator is, it's like a pacemaker that's surgically implanted, and then microelectrodes are actually dropped into the very deep part of the brain, the thalamus. So this is a surgery, interestingly, that's done while the person is awake. So if the person had dysmetria or tremor in the right hand, maybe they're having trouble feeding themselves, coordination is horrible, you would do deep brain stimulation on the opposite side, so on the left. And what is done is the scalp, the skull, everything is numbed up, so there's no discomfort with it. And then the surgeon is going to place that microelectrode into the thalamus while the person is doing things with their hand. And so you want to know you've got it in the right place because the tremor quiets down. This is it's a procedure that was originally developed for benign essential tremors or familial tremors. It's used in Parkinson's disease. The success rate varies quite a bit in MS. There's a target in the thalamus that you're trying to hit. What the neurosurgeons who do this sort of work will tell you is the target is more challenging in MS than it is in those other conditions. But it is still an option. I've seen it work very well in some individuals. And then I'm just going to close up with a couple of things that are on the horizon out there. Some of the robotic devices. So there's been a lot of interest over the years in exoskeletons. Until we come up with technologies to actually repair myelin and repair nerve fibers, which I do think we will have, these are sort of more robotic type devices to just sort of give you the muscles back through a robotic device. Some of the challenges that we've had with some of these devices is they're not always the most practical. The motor unit that is typically on the person's back can be quite heavy with some of these devices, but these are some of the different options. There's the Cyberdyne system, Kigo, exoskeleton, and then one that we're working with here at Shepherd Center is called the Indigo. And this is actually one of our employees here at Shepherd who's had a spinal cord injury from a motorcycle accident, and he's part of our research with the Indigo exoskeleton. I wanted to mention FES bikes. This is something that our researchers are very interested in. So FES, functional electrical stimulation. So the idea with an FES bike is that you put someone on a stationary bicycle, you have electrodes, little pads taped onto different major muscle groups. And as the person is biking, if they start fatiguing, the FES is going to start firing their muscles for them. And the question that we had with research is, does this then translate into better strength and better endurance in the real world? And in 2 studies, it has. So we'll have people work with FES bikes as part of physical therapy. We actually, through our wellness program, we actually have people to do classes with the FES bikes to improve their strength and endurance. And then lastly, this is one that's always been interesting to me, and I don't know why it's kind of gone quiet. So there was a lot of interest, I would say 10 years ago, in surgically implanted bions. So what the gentleman's holding there is a little, it's a nerve stimulator, and so it's surgically implanted over whatever nerve you're trying to stimulate, and then you would have basically a pager unit that's going to fire that bion and tell that muscle to fire. So maybe you put one over the perineal nerve for your foot drop, maybe you put one up in the hip area for your hip flexors, and then that bion's going to read when you need to step and fire the nerve for you. There was quite a bit of interest in this in stroke, spinal cord injury, MS, and it's kind of gone quiet here for a little bit, but we'll watch and see if it resurfaces as a treatment option. And I think with that, I will stop. And Casey, we will open it up to questions and thoughts, wherever people want to go with this.
All right, thank you very much, Dr. Thrower. So for our participants, if you have questions, you have 2 ways to get those questions to us. You can either use the chat feature. If you just touch your screen, or click your screen, you should see a box come up with a little chat bubble. You can type your question in there, or you can use the raise hand feature. Depending on which version of the app you're using, if you're on mobile device, it should be under the More menu with the ... on it. There should be an option to raise your hand. Or if you are on a computer, it should be on the Participants menu at the bottom, an option to raise your hand. And if you raise your hand, then I can bring you on the screen to ask your question live. While we give people an opportunity to type their questions in, I have a few questions that were sent ahead by email. One was, what do you think of trekking poles as an assistive device for gait instability?
Yeah, I think trekking poles can be awesome. I mean, they're super lightweight, they're inexpensive. I would say if you're going to look at something, and this applies to trekking poles, canes, really almost anything that we want to think of as an assistive device. Ideally, I'd love to have a physical therapist watch you use those and make sure that we're really using the right thing. So with trekking poles, like with canes, you want to make sure you have the right length. We want to make sure that we're not kind of forcing the person into a flexed or hunched position and making their balance work. But no, I have several patients who use trekking poles, and I think in the right individual, they can be great.
Okay. Karen asks, does foot drop ever get better?
So anything in MS can get better. So generally what we say, if you have a new symptom and it's been there for more than a year, chances are that one's going to stay there. But we do have people who prove us wrong. We have people who improve, a year and a half after the onset of a symptom. So generally years is our rule of thumb. If it's been there that length of time, we're probably stuck with it. I will say, research is not stagnant. And so the holy grail of MS is going to be neural repair and how do we reverse disability. So even if we think a symptom like foot drop is permanent right now, I would always say that there's that hope on the future, on the horizon, that we are going to have options that might reverse that disability.
All right, and our next question, let's see, just it just moved on me.
Uh,
Mary Lucia asks, are there any exercises for foot drop?
so yes, so it's tough because if you go to the gym, there's not really a machine that we have that works on on the foot drop. So you can think about things like calf raises or standing up on your toes that work the gastroc muscle, which is the opposite muscle, but that's not really what we need to work on in MS. So in working with a physical therapist, they can help you design some things. One of the common ones to do is to use one of the TheraBands, the big giant rubber bands, and make a loop out of it, anchor one end or have someone hold the other end, put the part of the loop across the top of your foot, and then basically what you're doing is you're pulling back against the resistance of that band while the other end is anchored down here. So that's one of the more common exercises that we do for foot drop.
Okay. Following up on that, Mady asks, can these type of exercises help with foot drop when there's no natural lifting of the foot or wiggling of the toes at all?
Yeah, if the weakness is that profound, I wouldn't, it's going to be tough. And so that may be where one of these electrical stimulating devices. So one of the nice things with the Bioness device is you are essentially rewiring your leg. You're making that muscle work again. And one of the things that's nice with the Bioness is there is an exercise mode. So you have this device on and you could be sitting on your computer, you're watching television, and you turn the device on and it's making your foot flex and you're exercising that muscle without you even really doing anything. And there is some evidence of what we call carryover with these electrical devices. So using it then sometimes leads to better function even when you don't have the device on through that kind of exercise and strengthening. Oops. Still there, Casey? Did we lose her? Uh-oh.
Can you hear me now?
Yep, I can hear you now. We lost.
Okay. Okay, bear with me 1 second. So Sandra asks, could there be something medicinal I can take to lessen my imbalance? Right now I'm holding on to walls. Walker and cane don't seem to help.
Yeah, so we don't really have a medication that improves balance. And again, we have to step back and say, well, why is your balance off? And most of the time when people describe what she's describing, it's probably going to be that sensory ataxia. It's the decrease in proprioception or position sense in the feet. And so really the best thing that we can do with that is work aggressively with rehabilitation, really working on the core strength to get better with that. Again, not a lot of people are aware of this other form of physical therapy called hippotherapy, so it's HIPPO therapy. Hippo is Greek for horse, and so not everywhere has that, but if you do live in an area where it's an option for you, there are different forms of hippotherapy. There are physical therapists who are trained in hippotherapy. So we have a facility here in Atlanta, Chastain Horse Park. Those are physical therapists who are trained in hippotherapy. The beauty of that is your insurance will cover it as physical therapy. Other places don't have physical therapists running their programs, and they're a little bit more of what we call therapeutic riding. That can still be beneficial. You need to look at the safety and the sort of how adaptable they are to maybe people with mobility issues. For instance, at Chastain Horse Park here, I can send someone there who's in a power wheelchair. I know that they have the ramps, the lifts, all the physical therapists to do that safely. Not all facilities are going to have that, but the idea behind hippotherapy is you're forcing your body to use those core muscles. And when that horse moves, your pelvis is moving with the horse just as if you're walking. So you're really engaging those muscles. And most studies have shown that people do seem to get improvements in balance by working with a program like that.
Related to that, Betty asks, Can muscles actually be strengthened in MS in a person in their late 70s? Hippotherapy, a recumbent bike, and water exercise seem not to be helping.
So so the answer is yes. There's no age limit on who can benefit from rehabilitation. The challenge is, so if a person is doing all of the right things, it may be that we're just not getting the signal from brain to spinal cord to muscle to be able to strengthen those muscles. That may be where something like an FES bike. So if we're saying, if I can't get the signal from brain to muscle, maybe I send a signal to the muscle from an training source like an FES, a functional electrical stimulation. So that may be an option in that situation.
Lane asks, I have pain in my feet by my arches and toes. It's uncomfortable. What could be the cause?
So we never want to automatically assume that all of our symptoms in a person with MS are due to their MS. So certainly MS can cause foot pain. So you can have what's called neuropathic pain or just hypersensitivity, burning sort of pain, and the feet would be one of the more common locations. Increased muscle tone, spasticity can cause pain in the feet like that. But a person with MS can certainly have other podiatric issues. They can have issues with their arch or plantar fasciitis. So we want to just be mindful that we don't blame it all on their MS. But if it is the MS, it's probably going to be one of those two things, either spasticity or central neuropathic pain. Sometimes it doesn't matter too much which label we use. Some of the treatments, especially with medications, would tend to work maybe either way. So things like gabapentin and Lyrica, or maybe even topical agents. I'm a big believer in topical CBD lotion, which is over the counter. So you can find good, high quality topical CBD, a hemp-based product, which is legal in all 50 states. And it's very benign. It's, no one's ever been hurt by topical CBD. Maybe worth trying for something like that foot pain.
Scott asks, do you know if insurance has covered the Bioness?
So the Bioness units, it is frustrating. They are FDA approved for MS, for foot drop in MS, and the insurance companies will sometimes still fight us on them. Just the basic Bioness unit is about $7,000. If you add the upper cuff to it, I believe that's another couple of $1,000s. So they are not cheap. We certainly fight with insurance to get those done. We actually, because insurance companies were not great about covering them, we actually set up our own kind of through our philanthropy, our own grant program. So we were able to identify a very kind and generous donor who will pay for the devices for our individuals with MS where insurance will not cover them.
All right, and we are coming up on the end of our time, but I want to get in one more question because I think this is something probably a lot of people are dealing with. Moines wrote, hi, I would like Dr. Thrower to address the recent shutdown and stay-at-home orders that completely derailed my exercise routine for 3 months and encourage us to get back on an exercise routine. I'm back at water aerobics twice a week, PT twice a week, and yoga once a week. Before the shutdown, I could walk 100 steps with just a gait belt and not holding on to the PT. Now I can do about 20 steps and have to hold on to the PT. It's so frustrating. I feel like I lost 3 years of hard work in 3 months' time. What encouragement do you have for people facing this situation?
I think the number one encouragement we can give is it can be regained. You can get that back. It's frustrating, and it's been so frustrating for us to see our folks going through this. We believe 100% in the importance of exercise and wellness, and so our wellness center down the street from us, we've been seriously curtailed in what we can do for folks down there. So it can be rebuilt. You can get it back. I think we have to be creative during these shutdowns and periods of social distancing. There are some online programs that are out there. There is there's MS Workouts, which is one website, MS Workouts, and then there's another called My MS Gym. From what I'm hearing from individuals who've used these two, they seem to like My MS Gym a little bit better. There is some free content on My MS Gym right now, but if you wanted to do the whole program, I believe it's about $30 a month to join. The National MS Society has some exercise content on their website. We are taking advantage of home physical therapists as well. So if people are having a hard time getting out and they're deconditioning, maybe we set up a short run of home physical therapy. Home PT is never as good as going to the facility, but right now it may be the best that we can do just to try to kickstart people and keep that function just going. I know it's been a big challenge for people, the deconditioning, but again, you can get it back.
Thank you so much, Dr. Thrower, for addressing that and for all of the information that you've given to our participants today. We really appreciate all you do.
Thank you guys, and everybody stay safe and healthy, and looking forward to a non-COVID time, hopefully in the near future.
So to all our participants, I'd like to thank you for being here and let you know that if you missed any part of this program, or you would just like to watch it again, it will be available on the MS Focus YouTube channel after a review period, so within a week or two. If you need a link to the YouTube channel, you can reply to the registration email that you got for this program, and we'll send you that link. And I'd like to let you know about our upcoming teleconference that will be on the 20th of this month. It's called Thrive While Trying to Survive, Strengthening Connection, Purpose, and Joy in Difficult Times. And that will be with our speaker, Lara Steppelman, PhD. We hope that you'll join us for that and future teleconferences. If you have any suggestions for topics that you'd like to see covered, we'd welcome those. Again, you can just reply to your registration email in order to contact us. So thank you all for being here, and we hope we'll see you again soon. Stay well.